everybody. Welcome to week four's content. We are entering the world of intrapartum nursing, which is also known as labor and delivery. And this week, we're really going to talk about the birth process and how nurses can facilitate normal physiologic birth. Let me hide that. So we have some outcomes. Let's establish those. By the end of this module, which will be 4 short videos, learners should be able to identify the factors and forces in labor, the 5 Ps, that might be the longest part of this, and discuss how each one influences the labor process. But we'll be referring back to the 5 Ps when we start applying that knowledge in how to help birth go better and faster. You should be able to describe the potential mechanisms behind the onset of labor and signs of impending labor. Identify labor has 4 stages. The first stage is split into 2 phases, and you should know roughly what happens in each one of those phases and how you can know where your patient's at. We will discuss important nursing assessments that are unique to labor and delivery, and some routine assessments that are important in labor and delivery. And we'll talk about how a nurse cares for the birthing person in a normal, routine vaginal delivery. We'll do C-sections next week and medical interventions, but right now we're really talking more about labor support in the normal physiologic labor process. We'll talk a little bit about venues for giving birth and the advantages and disadvantages of each, and I'll introduce you to the role of different disciplines in labor and delivery. But let's get started on the 5 Ps. Whoop, that was just an introductory slide. Don't worry about that. So here you have the passage. You don't see the cervix in this, but you do see the bony pelvis, which is made up of the innominate bones, the sacrum back here, and the coccyx, which is all the way down the bottom. It's like your tailbone. These bones are held together by joints and ligaments that get more movable during labor. And then there are soft tissue structures. The cervix is the lower uterine segment. It has a mechanism that opens and dilates to allow the baby to pass through the uterus. But you also have the pelvic floor muscles and ligaments that hold the uterus in place as well. Most of the time, your soft tissues don't obstruct birth. They can. I'll talk about that in a little bit. But first, let's talk about the bony pelvis. It was always considered that gynecoid is the most favorable shape because it's rounder. It has wider diameters. But newer research is suggesting that there's a wide variation in the shape of the pelvis and that the pelvis can change under the influence of hormones during pregnancy to expand, to become a little more flexible, a little more mobile. It's rare to have people who absolutely physically can't give birth, and it's very hard to have reliable assessments to do that. And so the thinking now, instead of doing all the measurements, I mean, you can guesstimate that something is going to be a tight fit and keep that in the back of your mind. But it's important to know that most pelvises are adequate. And they will accommodate birth. The inlet is on top, and that's the baby has to enter the inlet. It has kind of a different diameter at the level of the ischial spines. And I did have a slide on here with station. I'm not sure entirely what happened to it, but I'll get back to it. Anyway, the ischial spines kind of define where that pelvic inlet is. So when the baby engages in the pelvis, you can feel them at the level of the ischial spines. That's the inlet. The outlet, when we get to joints and ligaments, you'll kind of see the difference. The outlet is the bottom part of the pelvis. That has some different diameters, and the baby has to rotate to get through from the inlet to the outlet. And I want to show you, there it is. Okay, so there's the ischial spines, and that's where the inlet is, okay? And then the outlet is more on the +3, +4 side as the baby kind of moves down the pelvis. And as I said, the diameters change, and the baby's going to have to rotate. They do what's called internal rotation, and they have to be flexed. But that's the passenger, and we're going to talk about that next. When you're doing an exam, these negative numbers mean the baby's not engaged. So -1, -2, -3, it tells you how high the baby is. Once the baby's engaged, we can do an exam, and we feel from the inside for these little protrusions, these little bumps that you can feel through the vaginal tissue. If we can't feel them anymore, we know the baby's like +1. And you sort of get used to what +1, +2 feels like. But those are some of the landmarks. All right, and those bones are held together by joints and ligaments, as I said. This video is a little weird, but it does show you just how movable those joints are under the influence of relaxin, which is a hormone secreted in late pregnancy. See how those bones are actually moving. It's more than just a tissue. So when you're positioning mom or when you're helping her find movements, you can use that knowledge of anatomy and physiology to help that baby come down, to make room for the baby. All right. Okay. Next, we're going to talk about some of the softer tissues. So the cervix is what we think of mostly in first stage of labor. It has to keep the baby in for most of that pregnancy. So it's not going to be dilated, hopefully, too early. And it's going to stay thick and it's going to stay hard so that it's not easy for that baby to get through when it's still developing and it needs that. But at the end of pregnancy, certain hormonal changes are going to influence this so that the cervix becomes thinner, which is effacement. It starts out as thick. I'm going to make some models with softballs and modeling clay so you can kind of see the difference there. It has to go from that thickness to a real paper thin, what we call 100% effaced. Let's play that video. And it has to open. So it softens, it thins, it moves from my pointer here. During pregnancy, it's usually pointed towards mom's sacrum, but as labor progresses, to allow the baby better position to come out, it has to move anteriorly. It has to be, it has to come forward. So a lot of things happen to the cervix before it actually dilates. And let me show you a 24-second clip of what that might look like. Do you see how it went from being thick to getting thinner? That's effacement. Now it's like 100% effaced and it's dilating. It's becoming more open progressively. And you can think of this like putting a turtleneck over your head. That's exactly what has to happen. All right. Now, the only time the cervix gets in the way is when it won't dilate. So sometimes we have cervix with scar tissue or we don't have adequate contractions. That's the powers to open that cervix. Or mom pushes before she's ready while there's still cervix there and the cervix starts to swell. But most of the time, the cervix is not going to get in the way. You just have to be patient with it. We're going to move on to the passenger now. And before you start thinking, oh my God, I don't see any bullet points. How am I going to know what these slides said? I have slides that are only bullet points. But right now I want you to pay attention to what we're talking about. The passenger refers to the fetus or fetuses, depending on how many there are. If it's a multiple gestation, there will be 2 passengers. They help with birth too. They can impede it or they can help. So I want you to notice something about the fetal skull. 2 things. Number 1, it is not perfectly round. But if you're looking at the pelvis that's kind of oriented the same way, neither is it. So there's a question, if it was perfectly round, it could kind of come down any which way and it would be fine. But it's like those shape sorter puzzles that you have. It's an oval, so we have to line it up right. The other thing I want you to notice are the sutures, okay, and the fontanelles that are right here. They allow the baby's head to mold to the shape of the pelvis. Gives it a little flexibility. The pelvis is also flexible. And so even if it's, not a perfect fit, usually there can be some accommodation there. Nature built that in. Those fontanelles will close later in infancy. You heard about that in peds like week 1. But that's basically the fetal head. And that is usually the presenting part. It is the biggest diameter that doesn't collapse. So sometimes the shoulders look broader, but they can be smushed. The head can only be smushed so far. And when you measure the chest circumference and the abdominal circumference, they're smaller than the head normally. Now, when we get into shoulder dystocia, we can have a whole new conversation. But for right now, know that the head is the biggest part and it is the least malleable. It doesn't smush or collapse as easily as other fetal parts. So it's good for it to come first because if the head can come through, so can everything else. All right, passenger fetal attitude and lie. Attitude is not a state of mind in this case. Attitude refers to the degree of flexion. They have to curl. They have to tuck their chin into their chest. That's going to let the smallest part inch through, and then the bigger part can push a little bit more. It's just a way of making sure that that labor goes smoothly. Now, if that doesn't happen, if the attitude is what they call a military attitude or neutral attitude, you might end up with a face presentation or a brow presentation. And look at how much wider the diameter is there. It just doesn't fit. Same thing with the brow. It'll come down some ways, but then it gets stuck. And now you either have to unstick them and get them to flex a little bit, which is not easy to do, or you're doing a C-section. Here we have vertex, which is head down. We have flexed attitude. Here is a frank breech. So breech can come in a couple different categories. We have frank breech, which is butt first. We have footling breech, which can be 1 foot or both feet first. But that's a breech baby. This is a shoulder presentation, also known as a transverse lie, when the baby's kind of sideways. This doesn't work with vaginal birth at all. If you can't turn that baby ahead of time, it's not coming out that way. That is going to be a C-section. Usually these babies that are breech or transverse, we can do a version, and I'll talk about that next week. But sometimes they flip back, and it's what we call an unstable lie. They don't stay head down. Now I'm going to move my little camera box and show you. We have a whole new slide for that. But you can see, like if you were to do a vaginal exam, you could feel for fontanelles and kind of determine the position the baby's in. This is the anterior fontanelle, and there's the occiput. Okay, so the occiput's the presenting part. We're going to talk about that in the next slide too. I'm going to go over it in more detail. But if you feel those fontanelles, I just have a good picture in front of me. And the occiput is coming down first, and it's in the anterior portion of mom's pelvis. See, here's the symphysis pubis, and here's the sacrum. Now we know we have an occiput anterior. Now, if you were to do Leopold's maneuvers, you would feel for that back, and you would know that the occiput is on the left, and this baby is left occiput anterior. Let's re-go over that concept, shall we? So here are all the different types of positions. If the presenting part is the occiput or the back of the head, because that baby has nice flexion, flexed attitude, that middle letter is going to be O. I wish this graphic was a little bit clearer. I'll try to get a better one for you for class. So all of these that have the occiput coming down are left or right O something, okay? For the rest of that designation, you're going to have to look at mom's pelvis. So where the symphysis pubis is, that is the anterior. Where the sacrum is, mom's sacrum, and the coccyx, that is posterior. So where is the occiput? Well, in this picture, we have the occiput, and it's anterior. And the baby's on mom's right, which will be our left if we're facing her, right? So if I felt a back here, and I knew that the head was down, and I knew that the occiput, or the back of the baby's head, was in the anterior pelvis, I could very easily categorize baby as right occiput anterior. Transverse means they're sideways. You can have that. It's a variation. Posterior babies. These are sunny side up kids. And it's common, but we have to fix it if we want things to go smoothly. Some women can deliver in occiput posterior, but it's difficult. It's longer. It's more painful. They get back labor because all those nerves in the sacrum are getting pressure, hard pressure from a very rigid fetal head. Okay, so we don't like OP babies. Here, baby's coming down occiput first because he's flexed. Occiput's first. But the occiput is towards mom's sacrum. The baby is sort of towards the left, the body. So that baby's coming down in left occiput posterior. And there's our right occiput posterior. Again, the back of the baby's head is in the back of the pelvis. So those are going to be your two most common variations. Mentum is chin. Don't make yourself crazy with that. Please don't beat yourself up trying to learn that. And sacrum is a breech. It doesn't matter. They're all coming out wrong. I'm worried about OA versus OP because an OA baby will come out better than an OP baby. These other kids, they're either going to have to be turned in an external version or they're coming out through the vaginal bypass, the sky roof in the abdomen. All right. So other factors about the passengers. May have heard that size doesn't matter. Well, in this case, it kind of does. Don't giggle and don't report me. But bigger kids, it's a tighter fit. The smaller the baby, the easier the birth. Now, we don't want them to be low birth weight because that's a health risk for them. But in terms of fetal delivery, big babies are not healthy babies. They get stuck a lot. The problem is it's really difficult and imprecise to guess how much that baby's going to weigh. We have three ways that we can guess. We can do fundal height, take that measuring tape from the symphysis pubis, that's all from your week 2 content, and go to the top of the uterus or the fundus. And if it's way more than 40, 42, I mean, if you're looking at the abdomen and you see that it's way out of proportion to what you usually see at term, you could guesstimate that this is a bigger baby. Not a perfect science, depends on mom's height and who's holding the tape measure and a lot of other things. Another way you can tell from the outside with external assessments is Leopold's maneuvers. You give the belly a good feel, and after you've felt a lot of bellies, you kind of know which ones are big, small. You'll get that sense, but it's not precise again. The last way we can tell is fetal ultrasound. You would think that would give you a really good guideline, but I've seen them be off by 2 pounds or more. It's just not an exact science. So you have to kind of look at risk factors. Macrosomia is more common in people with diabetes. People who failed the 1-hour screen but then passed the 3-hour screen are at risk for macrosomic infants. People who've already had macrosomic infants, people who were macrosomic infants, and obese women are all at risk. The older you are, the longer your pregnancy duration, male gender, those things can also affect birth size. But at the point where the baby's like 4,000 to 4,500 grams, it's recommended that the obstetrician will recommend cesarean delivery as the mode of delivery. All right, so now we're on the powers. We're zipping through this. Here is a little 1-minute video. I'm going to talk through it. The powers refer to the uterine contractions and mom's pushing effort. So uterine contractions can actually exert about 50 pounds of force. And they'll push down on the baby to affect descent. And also the presenting part will put pressure on the cervix to let it open. Okay. So oxytocin is the hormone that's responsible for this. Works on a positive feedback loop. The more you're contracting, the more oxytocin your body's releasing. And oxytocin is also responsible for ejection of milk during breastfeeding. Again, works on a positive feedback. The more milk that's removed, the more the more oxytocin will come out, and the more milk the mom will make. Supply and demand. Labor works the same way. So oxytocin is going to be secreted in higher amounts in a normal labor, even if we're not giving the mom Pitocin. It's going to be secreted in higher amounts as labor progresses. Mom's pushing efforts are also important. Let's go to the next slide. I know I have something. Well, we'll get there. The psyche. The psyche is a very important determinant of labor. So think about how humans evolved, right? We have fight or flight response when we're in danger. Well, if you're being chased by a bear, it might not be a great time to squat down and have a baby. So oxytocin will kind of switch off in response to those stress hormones released by the sympathetic nervous system. But that also happens when mom is just feeling anxious. And moms who are coming into an unfamiliar environment, 98.4% of them give birth in the hospital, where they have little control, and if they don't have trust in their providers or they don't know what's going on, and then they're hit with pain that they didn't expect, it's kind of hard to predict the kind of pain you're in. Or maybe they have a labor that's going differently from their previous labors. Labor will slow down. Labor can stop. It can get dysfunctional where you're having contractions, but the impulses across the muscles are sort of twitchy, almost like an arrhythmia of the uterus. If you think of it that way, where the muscles are contracting, but they're not contracting effectively. So psyche is a really important thing. And things like continuous labor support, even hominess of birthing environments, um, allowing women to have choice in labor and honoring their preferences, their cultures, being respectful during birth, taking their pain seriously and trying to help manage it. All of those things will help mom labor better. Okay, the position, this is the fifth P. Well, it used to be four P's. And then they put position. I'm like, but position just kind of manipulates the other P's. So, position is really important. What your book says and what ATI says, they have like one little paragraph each that says gravity assists descent. And yeah, kind of. That's mostly true ish. But that's not the only thing that we do with positioning. We can use lunging, we can use side lying position with the peanut ball. What we're really trying to do is to help the passenger come down, and gravity does help with that to some extent if they're lined up the right way. If they're engaged in the pelvis and they're jammed in there some wacky way, we have to find ways to release that sort of stuckness. And so you're going to try and increase the diameter of the pelvis. You might even use the opposite of gravity, which is an inversion, to get the baby out of the pelvis and then bring mom back up kind of quickly and let the baby settle in, but in line. You want to line the hole up with the peg in birth, always. So we use positioning in all kinds of ways. When you have that OP baby, the one whose sacrum is on the mom's, whose occiput is on mom's sacrum, and you know that you have OP, even if you don't use Leopold's or a vaginal exam, because mom is going to complain that her back is killing her. She's not going to complain about the cramping. She's not going to complain about pain in her cervix. She's going to be talking about her back. And she's not getting relief between contractions because the baby's head's still there. It might not be pressing down, but it's still there. And it's hard. And it's putting pressure on all these sensitive nerves. We use a position like this one right here, hands and knees. Or we can, if she's in bed, she has an epidural, we can't get her out of bed, we can raise the head of the bed and have her hang off the back. Those positions right there will actually open up the pelvis. If the baby's way high and we need him to come down, he's not lined up wrong, but he's just up there, we can use things like squatting, because opening the knees opens the inlet. We can put her on a birthing ball. A birthing ball relieves pain and pressure, okay, because it kind of suspends mom a little bit. It allows mom to wiggle her pelvis or to bounce. And those motions a lot of times will help make some room for the baby. If we do it with the knees apart, we're opening the inlet of the pelvis. Now, if we want to open the outlet of the pelvis, we put the knees together, okay? And you'll put a peanut ball in between her ankles so that her knees kind of come in, okay? But that's positioning, and position should include movement. And I'm hoping this comes on without the sound. So she's kind of showing you a static position like squatting or hands and knees is only good if you're also allowing some movement. The movement is what's going to help shake the apples off the tree. It's going to help move the baby from side to side so that they can do that internal rotation and that flexion and get themselves in position. And you see, like, that pelvis opened up more when she was in different positions. So that side to side movement, the lunging, now we've got all these ads and stuff, but she kind of shows you all these things that you can do in birth. And we can do that in class as well. But don't stick mom in a labor bed that's a glorified gym mat on a hard rack of pain, and sit her in semi-Fowlers and not let her move. That's the worst thing you can do. All right. Now, if I get that video stop, I can move onward. Positions for second stage. There's, you'll probably see in clinical, a lot of people are laying on their backs and the nurse is kind of holding their knees up. It's a modified lithotomy or a semi-sitting position because mom's pulling back on her legs and she's curling around her baby chin to chest. And that curling motion does help the sacroiliac joint open up and gives a little more space for the baby to slide under the pubic bone. But pushing can take 2 hours, 3 hours. You do not want somebody flat on their back the whole time. It's not effective. It's not going to work. So you can have mom upright, These are pillows, but there's something called a cub chair, comfortable upright birth. It's an inflatable chair, inflatable birthing stool. You can have her on that in this position, leaning forward. You can sit her up with the back of the bed way up high so that she can push. But you want to watch the angle with that. You don't want the baby to get stuck on the pubic bone and they won't come down. She can squat with support, and you can do this the way she's doing it, or you can do it with a squatting bar. Okay. And a squat bar, if you've ever seen them, I'm going to go to work and take some pictures, I think, tomorrow. You kind of hook them into the bed, and then mom can lean on it, or you can get her a sheet and she can pull on it. That can be really effective. Lying on your side. People sometimes need to push on their sides. The baby sometimes doesn't tolerate pushing as well as we'd like. Pushing is stressful on babies. Second stage is the time when your strip, if it was beautiful before, it might have problems now. So lying on her side, someone's going to support the upper leg and someone's going to push back against the foot so she has some leverage and she doesn't slide around the bed. But pushing on the side is helpful. Kneeling with support, that's another good position. I personally, I don't see it here, but like real hands and knees, not this knee to chest business. Real hands and knees with the knees kind of together and the feet splayed apart. Hands and knees can be a really fantastic position to push out a baby, even with their legs apart. It works really well. It uses gravity, especially if they're hanging off the back of the bed. It's more comfortable, gets the baby off their sacrum. And it's just a super effective position for opening that pelvis up. Okay. Okay, and we are at the end of our presentation. So I am going to cut here and we'll pick up with part 2.